Professor Ajay Kakkar and the talk is kindly sponsored by Boring. Eric.
Good morning, Barry. Good morning to the meeting. Thank you for asking me to chair, and it's a wonderful opportunity to listen to the update on the Garfield Registry from the Honourable Lord Kakkar, who's also attached to the University of College London, where he's the head of surgery, as well as the director of the Thrombosis Research Unit in London. So please, Lord Kakkar, welcome again.
Good. And over the next 10 minutes or 15 minutes, I'm going to talk to you about recent insights from the Garfield AF Registry. And before I start, I'd like to thank Sylvia Haas, because Sylvia has served on the steering committee since the outset of this programme. The programme was conceived in about 2008-9, and we started recruiting patients in 2010. And she has been a quite outstanding member of the steering committee. And of course to Barry Jacobson and all colleagues in South Africa who have contributed, as you heard from Sylvia, to this study. These are my disclosures, which I shall leave up for a moment. And of course, the Garfield programme was supported by an unrestricted research grant that was made to the TRI for conduct of this study over the past 10 years. And as you'll probably recall, the Garfield study included some 57,000 patients with newly diagnosed atrial fibrillation across the 35 countries represented here. Of those, 52,000 are what I call the true prospective patients. Those are patients with newly diagnosed atrial fibrillation who were included in the registry within 6 weeks of the diagnosis of that AF. That is actually quite an important point, because we have tried to follow patients as accurately as possible from as soon as possible after their confirmed diagnosis of atrial fibrillation. And patients, depending upon which of the 5 cohorts they were included, were followed for a minimum of 2 and up to 8 years. Now, one of the most interesting observations from Garfield AF, bearing in mind that particular design of having newly diagnosed, consecutively diagnosed patients from randomly selected sites across the 35 countries, some 1,300 sites, is the ability to look at temporal trends in terms of clinical practice and outcomes. And you can see here the important observation from Garfield across the 5 cohorts of the change in clinical practice with regard to anticoagulation at baseline for patients with newly diagnosed atrial fibrillation. You can see in the first cohort, some 57% of patients presenting with AF considered at risk for the development of stroke, according to their supervising physician, received some form of anticoagulation. A small proportion of patients, the red here, one of the novel oral anticoagulants, the majority of those receiving anticoagulant, the blue, a vitamin K antagonist. But over time, you can see that the proportion of patients being anticoagulated increased from 57 to 71% of patients at baseline. And the proportion of patients receiving one of the DOACs, the 10A inhibitors or a thrombin inhibitor, increased substantially at the expense of the use of vitamin K antagonists and indeed single antiplatelet therapy, the green. What's striking is globally, despite being considered at risk of stroke, having a risk factor for development of stroke and atrial fibrillation, some 10% of patients globally presenting with atrial fibrillation did not receive any form of anticoagulation. Now, what you can see here is, despite the fact that there's been a substantial uptake of the direct oral anticoagulants globally, we can see here that there is substantial variation between country. And you can see here the NOACs now represented in a sort of orangey yellow colour across the participating countries, the blue being the vitamin K antagonist, light blue VKA alone, dark blue VKA plus or plus antiplatelet therapy, green antiplatelet therapy alone, and purple no intervention, that there is a quite broad variation in the way that we practice globally in terms of therapeutic intervention when patients first present with atrial fibrillation. But what is striking is by the 3rd cohort in Garfield AF, data here that were published by Sylvia from the programme, some 64% of anticoagulated patients were receiving a DOAC, which is actually a strikingly fast uptake of a novel intervention in clinical practice. Now, how has that change in terms of therapeutic intervention been associated with clinical outcomes for patients in the cohort? Now, one has to be careful in this type of analysis, but what we've sought to do here is to plot the change over the 5 cohorts in terms of therapeutic intervention: purple, no intervention; green, antiplatelet therapy; red, a NOAC; and the blue, a vitamin K antagonist, each plus or minus intervention additionally with antiplatelet therapy. And then look on the left-hand panel at the reported cardiovascular mortality rates across the 5 cohorts, and on the right, stroke and systemic embolism. And you can see that vitamin K antagonists, so there has been an improvement in terms of clinical outcome, in terms of reduced rates of reported cardiovascular mortality and stroke and systemic embolism. But again, if you look in a global study at the risk standardized mortality by country, you can see that there are substantial differences in the reported mortality rates across different countries. And that again is quite striking, and is something that we are now studying further as we have the mature and now fully locked data set across the entire globe. And one of the other important observations from the Garfield registry is that it is possible to segment patient populations and describe individual risk much more effectively. And the Garfield risk tool is now available and has started to be applied in routine clinical practice. Here, these are data we've seen before in this learned society with regard to the Garfield risk model compared to CHADS-VASc, with a better C statistic for the Garfield score compared to CHADS-VASc, and for bleeding, a comparison against HAS-BLED. This risk score was included in those reviewed and recommended as part of the ESC guidelines earlier this summer. The risk tool, now available as a web-based application, brings the advantage of being able to track the individual trajectory for an individual patient in terms of presumed all-cause mortality, stroke and major bleeding at baseline with or without anticoagulant intervention. But how important are the various elements of risk in terms of in the development of risk scores, and in terms of our better targeting intervention when we see patients with comorbidities presenting newly with atrial fibrillation? And here you can see the benefit of including in one's clinical assessment previous history of TIA in terms of all-cause mortality compared to that of a history of stroke, or the combined history of stroke or TIA. And you can see, as I say, the impact of that in terms of all-cause mortality, cardiovascular mortality, non-cardiovascular mortality, stroke, and major bleeding. And you can see, of course, that the most important impact in terms of the history of TIA is that in terms of its value with regard to predicting future stroke. But what about dosing of the non-vitamin K oral anticoagulants? Well, of course, there has been concern raised that outside the setting of the clinical trial, there's a tendency for the use of non-recommended dosing. And you can see here for the 4 direct oral anticoagulants, the proportion of patients receiving the recommended dose, orange, non-recommended low dosing, and non-recommended high dosing. So, of course, there are recommendations on the product label for variation in dosing. In this particular analysis, we looked for patients who had non-recommended dosing, and you can see here the proportions. And it is interesting that there is a variation both in terms of the amount of low dosing which is being used in patients in the real world, and indeed a small amount of excessive high dosing. And if we then look at the impact on outcomes, these are the blue unadjusted and the orange adjusted hazard ratios. You can see over here that there is impact in terms of particularly all-cause mortality, but also in terms of stroke and to an extent major bleeding with regard to inappropriate dosing, emphasizing the need that beyond the clinical trial setting, as we start to practice in routine clinical settings, we need to be sensitive to the, the dosing regimens that have been evaluated in clinical trials and apply those where appropriate to clinical practice. Now, Mr. Chairman, I'm now at 10 minutes in my talk, and I know we have to have some time for questions, but if I may, I shall continue for a couple of minutes. What was also very important from the Garfield AF registry was this determination to include patients within 6 weeks of the diagnosis of their AF, so that we could study the natural history, the early natural history of disease. And you can see here, for instance, in terms of all-cause mortality, how the greatest risk of dying, certainly in the Garfield cohort, some 57,000 patients, was early after presentation and diagnosis with atrial fibrillation, an important burden in terms of the natural history of disease that would have been missed with a longer period of time beyond diagnosis for which patients might be included. But this type of design has also helped us to try and understand what the consequences are of bleeding in terms of the first 30 days after a bleed, bearing in mind that a lot of the burden of disease occurs early after presentation with atrial fibrillation. And you can see here in this particular analysis, in terms of 30-day survival curves after presentation with either a minor bleed, a clinically relevant bleed, or a major bleed, how, of course, and intuitively, major bleeding is associated with the greatest burden in terms of reduced survival. But early in this first period of analysis, 30 days after bleeding, that the cause of death predominantly associated with major bleeding was a cardiovascular cause of death, suggesting that major bleed was associated with termination of anticoagulant or antiplatelet therapy and a subsequent cardiovascular event. But a landmark analysis looking at the outcome for patients after 30 days continues to demonstrate the particular burden associated with major bleeding. You can see here the comparison for minor, clinically relevant, or major bleeding. But major bleeding subsequent to 30 days was predominantly associated with non-cardiovascular death, a very interesting observation that we continue to evaluate. Now finally, it's also been possible to undertake forms of comparative effectiveness analysis in the real world population. This has to be treated with caution. There are important caveats, but we've been able to develop methodology here in terms of developing new weighting methods and propensity scoring approaches. And you can see from this type of analysis that compared to vitamin K as the form of anticoagulation for patients with newly diagnosed atrial fibrillation, the non-vitamin K oral anticoagulants are associated with lower all-cause mortality, a trend towards a lower frequency of stroke and major bleeding. Now, of course, this is quite intuitive. It reflects what was shown in the randomized clinical trials, but it's interesting to be able to demonstrate this in an unselected population of patients outside the trial setting. So in conclusion, Mr. Chairman, we have now completed the Garfield AF study, some 35 countries, including South Africa, the largest prospective global AF registry, with some 57,000 patients followed for up to 8 years. It represents a tremendous resource And we look forward to continuing to work with colleagues from around the world in terms of interrogating this interesting data set. Thank you very much indeed.
Thank you, Lord Kakkar. You did take your full 15 minutes almost. Just quickly, 2 questions. One, are you monitoring left atrial appendage occlusion? And is that the reason that maybe the aspirin is still continuing, or the antiplatelets?
We do have those data, and we will be publishing on that. There are a number of patients who have had other interventions for management of their stroke risk and atrial fibrillation, and that may well be one of the explanations.
And the last one is really differentiating amongst the agents with bleeding. Are you going to be publishing on that?
We are doing, using our techniques now, I think, properly validated to look at comparative effectiveness with regard to different therapeutic interventions.
And their bleeding rates.
And their bleeding rates, yeah.
Thank you very much.